Good morning, everyone. I hope everyone's had a good break. Just to say, I'm Anne Johnson, I'm Professor of Infectious Disease Epidemiology at UCL and President of the Academy of Medical Sciences, and I'll be chairing this session. We've got a fantastic team who are going to present to us today, and they're going to be showcasing some of the key impacts of the national core studies to date, and they're going to give us some concrete examples, and I've seen many of these in action, of how the core studies have influenced policy. So rather than me introducing them one at a time, I'm going to introduce all of them to you now as a team, and they've got their own order, and they'll be doing kind of relay where they pass on the baton from one to the other. But I'd like to let you know who they all are now, and some of the issues that we're going to discuss were raised in our earlier session. So let me encourage you as things go along to put questions in the question function so that we can have time afterwards. They're each going to stick strictly to 5 minutes, and then that will give us plenty of time to have a 20-minute Q&A at the end. So we'll look forward to that. So with no further ado, I'm going to introduce them to you. First of all, Professor Andrew Curran, Chief Scientific Advisor at the Health and Safety Executive, and then Professor Jonathan Sterne will follow, University of Bristol, who's Professor of Medical Statistics, followed by Professor Paul Moss, who will focus on immunity. He's from the University of Birmingham, where he's Professor of Haematology and Head of School. That will be followed by Professor Sir Ian Diamond, who is Head of the UK Statistics Authority and our National Statistician, who's going to be talking about epidemiology and surveillance. And then we'll welcome Divya Chadha Manek from the National Institute for Health Research, who's Director of Business Development, and she's going to be talking about about vaccine trials infrastructure. And then we've got the clinical therapeutics, which will be introduced by Professor Patrick Chinnery, who's Clinical Director at the Medical Research Council. And last but not least of this team of 7, we have Professor Andrew Morris, Director of HDR UK, talking about data and connectivity. So without further ado, over to you, Andrew Curran.
Thanks very much, Anne, and good morning, everybody. Great pleasure to be able to speak to you this morning. So I'm going to be talking about the National Core Study on transmission. We've been working away since October, and what we're trying to do in our study is to improve our understanding of how the virus is transmitted from person to person and how that varies between different settings and environments. And what we're hoping is that this improved understanding is going to enable much more effective measures to prevent transmission and therefore save lives, and to support society's return towards a sustainable new normal. The most important thing, I think, is that we are collecting data in the real world. And I like always to start my presentations with a picture of the real world, just to remind us that actually the UK economy has still been working during the whole of the pandemic. And that means that businesses have had to take measures to make sure that they can adapt to this virus and that they can provide an environment that reduces the risk of transmission. And you can see here on the left-hand side, a picture of a production plant, a food production plant, before they took measures to socially distance and identify approaches to provide that additional control. And on the right hand side, you can see that they've done things that are not rocket science, but very, very helpful at reducing transmission. And I think it's really important to send a real shout out here to UK industry, the workers, the employers who put a huge amount of effort into thinking through what will work in their specific environments and how they are going to take control to reduce transmission in relation to their specific areas. So how does that work in relation to the area of transmission? And I think we've thought how best to express this. And I think really what we've discovered is that there's a real link between 3 key areas, and the interaction between those 3 factors causes transmission to occur or not. So the first of those is human behavior, and a lot of our work is trying to understand how humans interact with their environments to ensure that we can identify the opportunity to improve the reduction in transmission. The next is the environment itself. What are the geographical issues, the physical issues, the layout issues of environments that can increase transmission? And then what are the characteristics of the virus itself that cause it to move around an environment and transmit to different populations in different ways? It's the interaction of those things that we're interested in, and how the complex mix of issues ultimately result in transmission in those workplaces or indeed other environments. And what we're trying to understand is what are the key issues that we need to address to enable us essentially to understand that. We know, for example, that transmission is a continuous risk. It's an everywhere, every time, every place issue. We know that there are 3 routes of exposure: air, surface, and person to person. We know that the control of those environments requires mitigation, not just on a workplace environment, but for each work activity and for each route of transmission, which means that people have to think very hard about what they're doing. And that the risks are affected by many factors. It's not this, what we've identified, for example, is that if you look at all workplaces of a similar type, they don't all have the same risk of transmission. So other factors are playing into that. It might be the demographics of the workforce, it might be the location, etc. So how does that work, and what questions are we looking to answer? Well, we need to understand the dose of the virus that's needed to infect someone. We need to understand how the droplets containing the virus are generated. We need to understand the viral load, how people differ in their characteristics of transmission, what happens in that physical environment to make the environment more at risk than others, and many other questions. And we've essentially divided our approach up into the themes you can see on this slide. We're looking at outbreaks and collecting data from real outbreaks. We have people with boots on the ground at the moment collecting information from warehouses, for example. We're using that information to inform our modelling approaches, which include both computational fluid dynamics modelling and agent-based modelling to test interventions. We're doing deep dives into sectors to understand what are the risk factors within individual sectors, and, for example, what supports enduring transmission in some specific areas of the country. We're doing experimental infection in animal models and in humans to collect data to enable us to understand those key questions about the dose of virus, etc. We're developing methods to help all of those activities, and we are ultimately bringing all of that together to decide what works and to provide simple, practical solutions to make a difference in the real world. And I think ultimately this is about how we provide the best information to make sure that people can do the right things when they need to do them to protect those people they're looking after. I will stop there and I'll hand over to Jonathan Sterne, who is going to talk about the next study. Thank you very much.
It's a great pleasure for me to present on behalf of my co-lead, Nish Chaturvedi from UCL, and on behalf of a very large group conducting the Longitudinal Health and Wellbeing National Core Study and the linked convalescent study, which looks specifically at long COVID. Our aims, and I cannot see this slide, are shown here. We aim to understand the health, social and economic impacts of the COVID-19 pandemic by uniting established population cohorts and national anonymised electronic health records to inform policy. We bring together a large number of academic institutions and NHS bodies and NICE, the National Institute for Health and Care Excellence. Importantly, we bring together the majority of the UK's population-based cohort studies that have followed groups of individuals over long periods of time from before the pandemic. So they have unprecedentedly huge detail on these people that can be used to understand the way that COVID has influenced all aspects of their lives. And we're working within the major population-based linked electronic health records. The NHS Digital Trusted Research Environment for England, which was established through the British Heart Foundation Data Science Centre, the SAIL Data Bank in Wales, EVE2 in Scotland, and Open Safely, which has established linked data on 58 million people in England with access to the full primary care record, accessed in a secure way that prevents disclosure of confidential information. And here are our research themes. I obviously can't possibly do them justice, but they include healthcare disruption, mental health, wider impacts on society, the longitudinal linkage collaboration, bringing together electronic health records with these population-based longitudinal cohorts, work on serology, work on vaccination, and as I mentioned, a large allied study on long COVID. So here are a couple of examples of how this works. We've been looking at the relationship between employment status disruption and mental health. This is work in the cohorts. And this work showed how effective furlough was in preventing mental health consequences. The most adverse consequences compared with people who were in stable employment were among the stable unemployed, but people who were no longer employed through the pandemic had worse mental health than those who were furloughed and therefore retained their income. And then our work has been extremely important in informing the rollout of vaccination across the UK. On the top left here is work from cohorts that showed before vaccination even took place, the groups most likely to be hesitant about receiving vaccination. So before the programme started, the NHS was aware of groups that might require special targeted information in order to ensure vaccine uptake. As vaccination was rolled out, Open Safely were able to monitor the uptake of vaccination, both according to ethnicity, but according to factors that you could only get from linked electronic health records, such as learning disability. These have been rapidly disseminated and have allowed targeting of vaccination and vaccination information by the NHS. We expect to have a wide range of policy, public, and professional impacts, which I've listed here, and which I'll be happy to discuss during the questions. Thank you for your attention, and I will hand over to Paul Moss, who's going to talk about the Immunity National Core Study.
Thank you, Jonathan. That was super. Lovely to be with you today. So I want to talk about immunity, which I think we know is key for understanding and overcoming the COVID-19 pandemic, protecting against infection, determining the severity of the mechanisms of organ damage, vaccine response, and long COVID. And what we did when we set up the immunity theme was develop a 4P approach. By studying infection, we wanted to study how we could predict outcome, protect against infection, understanding how the immune system can prevent reinfection, and as Patrick said this morning, learn to be out of the blocks for the next pandemic. And I was very fortunate with the leadership for this team. I did it with Doreen Cantrell. Jonathan Pearce, who's leading the COVID response at UKRI, has been tremendous in supporting us. We had a very strong oversight committee, as you can see, and Robert Leckler has chaired our advisory board. I'm very grateful for their support. So the programs that we started initially, and this was in a pre-vaccine world, by the way, we were interested in shielding, which you think has probably been done all around the world for vulnerable people, but actually is relatively unusual. And Helen Snooks in Swansea has been addressing this. We were interested in immunity in different demographic groups, and we've set up programs in Leicester to study an ethnicity in particular, and also a large student cohort of 30,000 led from Jessica Corner's group in Nottingham. And we were interested in early and late complications in relation to immune response. And here I would signpost you to Muz Hanifa from Newcastle, who's going to give a fantastic talk later in one of the rapid talks. And finally, optimal cellular assays. We know that antibodies are useful in measuring immune responses, but what about cellular? They've been neglected, and we've taken on that challenge as well. So this was a 4 nations approach. We invested across the UK, and these are all continuing. But as we move to the next year, the vaccines, of course, came out on the 9th of November and have transformed things. And we've got new challenges. We've set up a very large analysis of the immune correlates of vaccine response in immune suppressed people. This is 3% of the UK population at least. And we've invested so far £4 million in this, studying vaccine responses in cancer, patients with cancer and inflammation, kidney and liver disease, and also older people. And again, I would signpost you to Helen Parry's talk later on this morning. She will talk about the strong contributions we've made in that area. We've also chosen to open up the funding to calls from across the groups across the UK. We have 2 open calls. One of these is on immune mechanisms that underlie reinfection or vaccine failure, and one is on optimal cellular assays in collaboration with industry. And this just shows a web link to the calls. This was a small business research initiative with Innovate, and it's delightful to work across the UK, across the UKRI in this call, and the panel meets very soon to assess this. And this was our second open call. Very, very important, understanding why vaccines can fail people and also why people can get reinfected. And again, that panel will meet very soon. So have we delivered things? Always interested in the science, of course. Yes, we absolutely have. Here are some exemplars of what we're doing. Helen is already analysing shielding policy, some quite intriguing results which will be reported soon, but also looking at the burden of shielding personally, economically, and in society. And Ken Smith in Cambridge runs our National Cytokine Autoimmunity Group. This is a group of patients in Cambridge Ken has been studying after days of admission. And these purple patients here with very severe disease all have autoantibodies against interferon, which is phenomenally important, and we need to understand how we can overcome that. In relation to PROTECT, we have a very large study of ethnicity, immune-based study of immune response in Leicester from Manish Parekh. And Manish has also got 1,000 people under study to understand how SARS serostatus impacts on the flu vaccine response. Absolutely critical this winter. And our OCTIV consortium is just involved this week. We hope to finalize funding for a booster vaccine study, which is very important and necessary. And then finally, yes, we are preparing for the next pandemic, building novel population cohorts, developing new immune therapies, developing a UK immunology platform, hopefully personalized risk for patients, and supporting industry investment. So a lot of exciting work ahead and policy initiatives and advancement. And with that, I will go to Professor Sir Ian Diamond.
Thank you, Paul. Thank you very much. And could I get the next slide, please? And the next one, please. Firstly, I'm just going to talk a little bit about surveillance and some of the work that we have been doing in looking at the prevalence of the virus right across the United Kingdom. And we have a study, the coronavirus infection study, which takes swabs from close on 200,000 people a fortnight, and also blood samples from a very high proportion as well, and produces separate estimates on a weekly basis for prevalence in all the regions of England, as well as in Wales, Scotland and Northern Ireland. And that has, I think, had a lot of impact in understanding the trends in the disease. If you look at the slide in the top left-hand corner, you can quite clearly see, as one moves through last autumn, the rise, the impacts of the restrictions in November, and then the increase around the turn of the new year. And we continue to monitor this and use it also to assess the relationship between vaccine uptake and antibody uptake. And there is a really, really strong association between those two, which also has enabled us then, because of the longitudinal element of the study, to be able to look at the efficacy in, if you like, the real world. And one of the things I think is incredibly important about studies like this is because of the asymptomatic nature of many of the cases, you do need, I believe, asymptomatic testing. Next slide, please. We've also been looking very carefully at the social aspects of the pandemic with a weekly social survey that goes out on a Wednesday. We close it on Monday mornings and publish by Monday lunchtime. And here, just looking at social distancing, it's also looked very closely at anxiety and depression and mental ill health, at issues, say, around face masking, issues around travel that have been so important to people. And again, the two studies are just there, link very closely together, because I think it's incredibly important that we have both the biomedical and the social elements. Next slide, please. In addition, we have been looking at vaccine hesitancy and had the first results on vaccine hesitancy and have shown the over time reduction in vaccine hesitancy. Next slide, please. We've also linked our data from vaccine uptake on a daily basis with 2011 census and with pre-existing clinical records, and that has enabled us to be able to look at some of the differentials, not only in hesitancy amongst people from different ethnic groups, but then about uptake of the second vaccine. And I think it's also important to say that these opportunities to link data, and I know that Andrew will talk later about the public health data asset, but the opportunity to link data, not just biomedical data, but social data and economic data, is incredibly important. Which allows me to say a few words, if I may, about the economy, because I do think, as Andrew Curran has already said, incredibly important that we monitor what is going on and understand what is going on in the economy. And we use a number of very radical approaches to do that. For example, using financial transaction data to look at how the consumer is spending, or web scraping of vacancy data to understand vacancies and to be able to say in real time that we are now, for example, having vacancies back just about at pre-pandemic levels. And those kind of statistics delivered at pace, I think, are exactly what is needed, as well as to understand what business is thinking about with regard to business sentiment. And we have a regular large coronavirus infection impact on business survey that businesses fill in, and we've been able to look at the impact of furloughing. We've been able to look at business sentiment around investment, all of which is incredibly important. And the final thing I would say on all this is that this is team science. The questionnaires are designed by contributions from scientists and from government departments in a way that makes them most impactful. So thank you very much for listening, and I will pass on immediately to Divya.
Thank you so much, Ian. And so just to set the scene, really, the aim for the National Core Studies vaccine infrastructure wasn't actually about individual studies, but actually about the infrastructure to deliver the vaccine trials in the UK. So the purpose was twofold, which was supporting the manufacturers of COVID-19 vaccines to support them with the development of the clinical evidence needed for marketing authorization. So actually we can get vaccines to us faster. And the second aim was to support the infrastructure and research studies that would support more evidence-based policy decision making. So the entire infrastructure for vaccines was through a collaboration with key stakeholders, which was led by the National Institute of Health Research, but working in partnership with the devolved nations. This was a UK-wide approach, and the Vaccine Task Force and other regulatory agencies as well. So the key aspect, I guess, is that there have been 17 studies that have been supported in the UK across vaccines research, and 42,726 people have been recruited for those crucial phase 1, 2, 3 and policy studies in the UK. Next slide, please. So what did we actually do? And like I said, this wasn't just a single stakeholder engagement. This was about the UK system working together. So the key first aspect was to ensure that the regulatory system was agile, pragmatic, and supporting fast tracking of applications. So you'll see on here the MHRA, the Medicines and Healthcare Products Regulatory Agency, and the Health Research Authority were expediting the regulatory approvals to ensure studies were set up really quickly. We then had, working with our partners in the national core studies and working with other organizations, we were able to get real-time data on lab confirmed cases. And so we were able to send the research workforce in the appropriate places with outbreaks as they were needed to recruit to vaccine studies. Next slide, please. There was a nationwide expedited study streamline set up with standardized clinical agreements, single costing methodology, which the NHS sort of bought on to ensure. NHS England also supported us in ensuring that vaccine studies were set up and contracted really quickly. Rapid site identification. So we had a regional model, which was never used before, with 15 regions and the 3 devolved nations, and a scale up of infrastructure to be able to recruit high volume patients for the NHS systems to be able to cope to recruit high volume participants as quickly as possible to the vaccine studies. Most importantly, we were able to set up a consent to contact for vaccine trials, which is called the NHS Vaccine Research Registry. We now have 505,000 people signed up to the registry, and this was all about having defined patient population. So people with comorbidities, people in different age categories, people with frontline occupations, and people of different ethnicities, to ensure that the studies that we supported, that the vaccine studies had equitable spread of the right people that were needed and were being tested in the right groups of people. And finally, the other objective was to ensure that whilst we rapidly recruit participants and rapidly deliver and generate the clinical evidence, that there was enough testing capability in the system to support the study. So whether there was PCR supplies, enough testing for the T-cell responses, or enough capability in the UK to support more VNA testing as well. So this was all about the infrastructure to deliver vaccine studies in the UK. So just to kind of just to touch base about what the next steps were. So we have been very successful in supporting all the vaccine studies for registration. The next focus is really about supporting using the research, using the same infrastructure to answer the questions that support policy decision making. So questions like, can we mix and match vaccines? Can we give the flu jab alongside the COVID-19? Can we, what's the time difference between between 2 doses, which is the 3rd dose? What do we do? The variant vaccines as well. So the infrastructure that we set up is the next steps of that is to really support all those other questions that we're now asking about the vaccines, to ensure that we're looking at the next wave and what we need to do to support that. So with that in hand, I will now pass over to Professor Patrick Chinnery, who will talk about the clinical trials infrastructure.
How's that, Anne? Great. Apologies. It seems to have a mind of its own. Pleased to meet you all, and thank you, Divya. I'm going to give you an overview of the clinical trials infrastructure that we've helped to assemble over the last 12 months and end with some reflections about what the next steps might be. Before I do so, I'd just like you to cast your mind back to March 2020 when the new virus was ripping through the country. It was poorly understood. The disease mechanisms weren't understood, and there were complications emerging that we'd not seen before with other viral infections. The number of hospital cases was increasing and mortality was starting to increase. And the truth was, we had no treatments for this virus. And there was a huge response from the clinical and academic community over 6 weeks in partnership with the pharmaceutical industry to find creative solutions to this problem. This was catalysed by the funding calls from the main UK and charity funders, and it led to a profusion of ideas, not least in the space of clinical trials. This, unfortunately, led to a degree of duplication and a bit of competition. And during peacetime, these are usually good attributes of science because they ensure the quality is very high and we can get reproducibility of findings. But when there's an emergency, it's not optimal. And it was realised that there needed to be coordination for us to have maximal impact. And the main aim of the National Core Study in Therapeutics was to construct a coherent trial landscape, including across the devolved administrations, by reconfiguring some of the existing trial platforms and integrating them into a complete portfolio. So how does it look now? Well, this slide shows the phase 1 to phase 3 landscape. You'll be very familiar with the recovery platform mentioned earlier. On the right, these are large studies with thousands of people testing specific new treatments for COVID. In addition, there's REMAP-CAP in the intensive care setting predominantly, and Principal in the community setting. And you'll be aware of some of the discoveries that these platforms have made. But in parallel, we assembled and reconfigured a phase 2 platform across the country to allow us to explore newer medicines, which we weren't quite sure how they worked. And feeding into that, on the left, you can see the phase 1 platform for completely new treatments that had never been tried before in man, and certainly not in COVID-19. And we now have this portfolio of studies working across this landscape. Next slide, please. Over the last few weeks, we've been putting in place a prophylaxis study platform, both for vulnerable patients who aren't responding to vaccines and also in care homes. These are for treatments that might prevent infection taking hold in high-risk situations. And next slide, please. As you've heard from Mark Toshner earlier, we have platforms looking at complications beyond hospital, the long COVID complications, as described by him in the HEAL platform. And the key element to this was coordination, and particularly a mechanism to identify the best possible drugs based on the best possible scientific evidence and to use them at the right stage in the disease. And for that reason, Professor Chris Whitty asked us to assemble an advisory panel, the UK COVID Therapeutics Advisory Panel, which is a group of independent experts who are looking at suggested treatments from anybody in the community. An open web portal on the government website has hoovered up all suggestions, and we've done due diligence on this and made recommendations into these platforms to provide a coherent, comprehensive understanding of treatments. So what have we delivered? Well, you're aware of the trial outputs, dexamethasone being the first one from recovery. But I think by showing we can assemble this platform of trials across the country and across the landscape, and showing we can recruit in hundreds of hospitals with tens of thousands of people joining in these trials, we've shown the world the importance of this strategy. And in fact, this has been lauded by the World Health Organization, the National Institutes for Health in the United States and the European Union. And they've been working closely with us to align their approaches to what we've assembled in the United Kingdom. And we've made a platform that we can use for future waves of the pandemic and also for other diseases, as Jeremy mentioned in his opening remarks. In the last few seconds, how have the National Core Studies helped? Well, we've been working in partnership with the other National Core Study working groups. And a good example is how we worked with the Data and Connectivity Group and the Vaccines Group to promote recruitment, particularly into the community studies, which was challenging when GP practices were not operating with face-to-face clinics. And we did that working with NHS Digital to tap into the track and trace system to boost recruitment into the Principal study. And looking ahead, data linkage is key. And I think one of the most exciting prospects is linking this trial data with other data sets, some of which you'll hear about in the flash talks, to allow us to provide precision medicine to patients with COVID and other infections moving forward. And with that, I will segue to my colleague, Andrew Morris. Thank you.
Thanks, Patrick. Terrific. And well done, Patrick, for finding the unmute button after 16 months. So well done. So I want to talk about the Data and Connectivity National Core Study. This has been a real team effort with Caroline Kate, David Seymour, Lara, as well as the ONS team, Ian Diamond and Pete Stokes. The thesis is that we want to make the whole greater than the sum of the parts. So as you can see, the verticals are the studies that my colleagues have talked about. But how do we connect these studies? And the thesis is that we use data and communication to really add value across the study. So I want to talk about data and connectivity. Next slide, please. And key to this is three things. Firstly, recognizing that at the start of the pandemic, data are often very fragmented with lack of standardization about how data are described or how you access data. So the three challenges were to map the data at scale for the population of 66 million people, accelerate access to the data for prioritized research questions, and thirdly, to muster the research community across academia, the NHS and industry to answer the key questions relevant to the pandemic response. And it was really important that this was across the 4 nations, and it was absolutely vital that we involve patients and the public in everything we do to demonstrate trustworthiness. Next slide, please. So this is a map of the data estate of the UK, working in partnership with ONS, NHS Digital, Scotland, Wales and Northern Ireland. We can now see where data are held in trusted research environments. And the NHS Digital ONS Public Health Research Asset is one great example of that. So that starts to map the net data. Next slide, please. But then we want to use the data for important questions. So for the last 16 months, we've been working with colleagues in SAGE to report on the use of health data across the UK in terms of how has it answered key research questions. And currently we estimate there are over 1,400 research outputs, over almost 800 researchers collaborating on 344 projects. And the real added value is when we link data that is curated normally during care, journeys of care, with COVID-specific data sets. For example, the REACT study, the COG-UK study, the genomic study, the Open Safely data set, the ISARIC data set, because that will give us a real high resolution of COVID across the UK in a multimodal way. Next slide, please. But to do this, one needs to demonstrate trustworthiness, as we heard in the previous session. So we've been really privileged to work with hundreds of patients across the UK to guide us in terms of what are the research priorities. If we want to embark on a research project, how do we design it so it demonstrates trustworthiness? And thirdly, how do we communicate with the publics so that there's a virtuous circle and the patient and publics guide our research? And I think this is absolutely vital if we're going to demonstrate the safeguards and the good use of data for the public interest. Next slide, please. Of course, we don't have all the data that will be required as we prepare for the next phase of the pandemic. So we're working with colleagues to look at, can we look at diagnostic codes from acute admissions data so that we know what's happening with patients when they're admitted to hospital? Can we look at data held elsewhere, for example, occupational data, which will be vital in managing the pandemic response? Can we look at the genomic and multi-omic data, whether it's host or viral genomics, working with Kenny Bailey and Sharon Peacock? And can we link vaccination data with outcomes data for safety and effectiveness? So these are data sources and programs which are being mobilized currently. Next slide, please. So this is the only map I'll show, but this is what we call a trustworthy federated data ecosystem. And if we get this right, it will be a legacy not only for COVID, but for other chronic and complex diseases which will face challenges, pose challenges for the UK population. Next slide, please. So to summarize, I would argue it's about coordination and connectivity, not command and control. We need to demonstrate trustworthiness in everything we do, and this concept of data as infrastructure is important. The under the bonnet stuff of governance, standards, the plumbing, and how we describe data is important. And I think there's a key issue around how we incentivize trustworthy data sharing. And I would argue there's a key role for funding agencies, journals, and research funders as we do this. If we crack this, then the UK can be a flagship of trustworthy open science practice globally. We're not there yet, but we look forward to working in partnership with you to make it happen. So back to you, Anne. Thank you very much.
Well, thank you very much, Andrew, and thanks very much to the entire team, who I think you've just demonstrated seamless teamwork in passing on to one another. And I think that is a core message from all this, that the core studies have all been about building infrastructure, working together and making, as Andrew said, the whole greater than the sum of the parts, but a long way to go, lessons to learn and things to look forward to in the future. But I've got a great long list of questions here, which I'll try and put some of them together. But let me start with some specifics, because there's some great questions here. One for a couple for Andrew on transmission, Andrew Curran, that is, going back to the beginning. And a couple of questions for you here, Andrew. The pandemic has educated the public about how to reduce transmission, face masks, hand washing and so on. But do you think we're going to go on doing these things for years to come? And do you think that's going to translate into fewer cases of flu and other more historic viruses each year? So interesting question about how we're going to behave. You raise behaviour as a big issue. And the other one is a question about the pilot events, which people will be very interested in given the football season. How do public pilot events, sporting events and so on, concerts, feed into the transmission core studies? And the James Pickett asks, my observation is these events seem high profile in the media, but the scientists behind these programs and the data generated are less visible. Any comments, Andrew?
Thanks so much, Anne. Yeah, two great questions. Starting with the behavioural question, I think it depends how we as a society respond going forward. So clearly, in addition to the reduction in transmission of the virus that the non-pharmaceutical interventions have delivered, they've also delivered some benefits for other respiratory issues. Flu was a very low flu season last year, and I understand that some other sort of more chronic conditions have also been reduced in relation to their impact. So I think it's a question for us as a society as to how we decide to take the best things from that sort of new world that we're living in now and use it perhaps to reduce the impact of respiratory infections going forward. Clearly there are pluses and minuses on both sides, but I think the question now has to move into that sort of societal tolerability of risk question, which is really important to get to grips with, because that will help us work out what we're aiming for when it comes to the mix of vaccination, non-pharmaceutical interventions, therapeutics, etc., that we need to achieve that particular objective. On the pilot schemes, as the National Core Study on Transmission, we're closely aligned to the pilot events that are going on, and we have regular meetings with the team who are delivering that work. For us, the information that's been collected there is extremely valuable to fill some of the data gaps that we have. So, for example, collecting information about where pinch points occur in venues and the ability to socially distance in those particular situations. The use of carbon dioxide as a marker for exposure in relation to failure to control crowds. So lots of things that we are using in developing our own national core study, but also helping those pilot events in delivering what they're delivering as well. So I think we developed a really good partnership there. Thank you.
So Andrew, can I just add to that a question about household transmission? People have commented that you may make a venue safe, but then a lot of transmission goes on in households. Are we paying enough attention to informing the public or understanding that as well? Do you want to say a few words about that? That's a big source of transmission.
Yeah, absolutely. And, you know, the first point that we always make when any of us are speaking from our national core study is that transmission is a continuous risk, and you can't just think about it in individual settings. You have to think about it from the minute you wake up to the minute you go to bed, because there are opportunities for transmission, not only in your home, but also on your journey to work, your journey to school, your journey to the supermarket, whilst you're in those locations as well. So I think critical to that is empowering citizens to make informed decisions about what they can do to protect themselves from others and others from themselves. And that includes, assessing the environment in which they're present and thinking about how to control those three routes of transmission: air, surface, and person to person. And as I said, I think in my presentation, some of the things that people can do aren't rocket science. Wearing a face covering, being socially distanced in those kinds of situations will all help to make sure that wherever you are, whatever you're doing, you're limiting the opportunity either for you to transmit the virus to others or others to transmit the virus to you. Thank you.
Okay, thank you, Andrew. So this is probably a question for you all. How have the national core studies involved patients and the public in co-development of their research? Andrew Morris raised this as a very important issue, but I wonder if others of you would like to comment on some of the specifics. Patrick, is that something you'd like to talk about in the context of the trials, or Ian?
So very happy to comment.
Go ahead, Patrick.
Would you mind just repeating the question, because the question kept breaking? What?
Oh, I'm sorry. I hope people can hear all right. How have the core studies involved patients and public in co-development of their research? So some of the specifics of the kind of things you've done with patients and the public in your research program.
So I can develop an idea I mentioned in my talk, which is the notion that we might tap into early diagnosis to improve recruitment into clinical trials, give participants the option to join clinical trials. A key step in doing that was to engage patients and the public in the concept. Were they happy for us to share data in order to do that? And so there was a work stream convened at an extraordinary pace around Christmas time last year, where 1,000 patients were contacted and asked their views about whether or not this data sharing was considered to be acceptable and in their interest. And that helped us steer the strategy that the different themes brought together to improve recruitment, which we saw in coming weeks in terms of the figures. Thank you.
Thanks very much. Did anybody else want to come in on that particular point? I can move on to another.
Just say, and if I may, we are constantly in conversation with our respondents and with potential participants and the public in general about the work that we do. And it is based very much on a partnership with the public. And one of the key things that we are passionate about is that we listen and we are seen to change our views to reflect the public's views. I think it's incredibly important that one doesn't, if you like, talk at. It's a partnership with, and that's something that we are absolutely clear we do the whole time. Thank you.
Yes, so Paul, and if I may.
Go ahead, Paul.
Yeah, sorry. Through the UKRI Coronavirus Immunology Consortium, we've got a panel of 10 PPI members, and they've been really instrumental in guiding our research policy and making us ensure that the work is comprehensible. Not writing lay summaries as they write it, but plain English summaries. So on all posters and outputs. So that's been really helpful for us.
Any other comments, or we move on to something else? There are a number of questions on equity, and there's one here on has vaccine rollout through the UK really been equitable, or is it proportionate to the size of the population? For example, London appears to be awash with vaccines which are being administered to thousands of people at one venue in one day. So any comments? This might be one for you, Ian, but others may like to comment.
Well, my observation of our work is that it has been equitable. I think it has been an enormous effort to bring volunteers right across the country into village halls, into motor museums, into sports centres, you name it. There are vaccine centres everywhere. There are mobile vaccine centres on the islands off the west coast of Scotland. And I do think there has been an enormous effort to enable accessibility. In fact, I think some of the problems are almost in some of the cities where it may be difficult sometimes to get across the city. And I think that kind of role of volunteers has been incredibly important. I know in January there were cohorts of people who were driving the very old to make sure they could access vaccines. And I would say that at one level, that's observational. Then if you look at the evidence is the very, very, very high proportions of uptake. And increasingly, as we have seen, as people are reporting to us, lower levels of vaccine hesitancy that is being matched by increasing levels of equality in uptake. Thank you.
Thanks very much. And so there's another question here about long COVID, which I think this is one for Jonathan Sterne, because I know you're doing a lot of work on the cohorts. Where are we in terms of setting up a national registry for long COVID, and how feasible is this? It's very topical because this is top of the news today, some of the work you've been doing. Yeah.
So codes to record long COVID were introduced into primary care in the second half of 2020. I mentioned work by Open Safely, and they've recently shown that these codes are actually being used far too rarely. So the codes are there for the GPs to use, but they haven't been used. We're working with the new secondary care services to ensure that the data on people who get into the services are linked to the other data. So this work is really in its infancy. This is a disease that didn't even have a name a year ago, and that is now going to be a major focus for years to come. And registering will depend on identifying people. And at the moment, we're working on what should be the definition on the basis of which that identification happens.
And if I could, just to say that there's a great group led by Kamlesh Kunti at the University of Edinburgh that Jonathan and I both attend, which is really trying to bring some of those questions that Jonathan has rightly described together. And I do think we need to move forward, as Jonathan said, to getting some really clear registration, because the estimates at the moment are really very high, and therefore we have a real challenge to address. Thank you.
Thanks very much. So I think we should move on. There have been a lot of general questions about how do we feel the core studies should be taken forward. Are they going to be continued into the future? What have you learned from working together? And what would you like to see in the future to take forward this kind of infrastructure? Should it be continued? Would there be a perfect solution in the future so that we are prepared and able to continue this work together? Just a few reflections on working together and where you see the future of core studies going. They've been a huge investment and we may not be able to go on forever. What does the future look like? How do you want to work together? Who would like to tackle that one?
And I can make a start on that one, because one of the key things that we're looking at currently within the vaccines work is the infrastructure that we've stood up. How can we collaborate with some of the other infrastructure? And Paul Moss, for example, spoke about the immunology network and how do we bring together the research delivery of the vaccines alongside the immunology experts to really harness a great UK offer to bring more research into the UK, to ensure that we're doing more of these studies. So on the back of all the work that we've done in vaccines, we're now looking at the next flu season, the research that's ongoing there and how we're pulling that into the UK, the testing capabilities, upping that as well. So there's a huge piece of work on what I would call the legacy of what we've actually been able to achieve over the last, 18 months. and taking the bits that we know can really make an impact on reducing timelines and squeezing the system to get better results as quickly as possible. So there's already some aspects of work that are in motion.
Anne, could I make an observation quickly?
Well,
and that observation
quickly,
is
we're on 0. We've run out of time, but very quickly, Ian.
Okay, I won't say the first thing, I'll just say the second thing. Yes, it's been a considerable investment, but the cost is massively tinier than the impact of a major pandemic that you are not ready for, with a team ready to do the sorts of things that this group has done and which can impact positively on it. It's tiny money in terms of prevention compared with the potential cost. Thank you.
Thank you very much. So on that very positive note, we hope you feel this has been a good investment. We've learned a lot from you today. We've learned a lot about teamwork. There are a bunch more questions for you all to answer, some specific. We might get back to one. In the meantime, thank you all for being here with us. We could have gone on for hours. Lots of questions to ask, but thank you for your time. We are out of it. So go well.